As you can see, I'm not Cassie. So we're doing EMCCM. This is our chief complaint. Those who don't know me, I'm Guy Carmel. This is actually a topic that everyone knows that I'm really into. Cardiology, EKGs and stuff. I guess you can say nothing gets my heart racing like someone's heart racing. There's supposed to be a rim shot there. I guess it did.
It's there in my head.
There it is. Before I move on, I got to give a lot of thanks to the wonderful Dr. D'Souza, Dr. Chan, Dr. Johannes, and Dr. Padlino, who hopefully will be arriving soon because he's our star. Mute. Alright, let's get started. So this is our triage. You can see, some lightheadedness, shortness of breath, palpitations. These vitals actually looked pretty normal, but they got brought back to the provider right away because there was some other abnormality. So we're going to kind of go through this. So whenever a patient gets brought to you and someone asks, what's the first step in management? I want to hear it all in unison. What do we do in the ED? ABC, ideal monitor. Very good. And this is a palpitation talk, so let's throw EKG on there. So airway, the patient was speaking to you, full sentences, that looked good. Breathing, okay, so you listen to the lungs, bilateral, equal, nothing really abnormal there. Circulation, right away you can tell patient's tachycardic, but the triage note said 70. Well, this patient's tachycardic, pulses are good, so we put him on the monitor, whatnot. Let's get the EKG. This is where the meat of this talk is going to be. So I'm going to call on, let's say, a second year maybe. I want somebody to just start telling me what you think of this EKG.
Tachycardic picture. Yeah. Maybe like electrical alternans. I don't know. Yeah, it's hard to go with the P waves on.
Okay, so here. Electrical alternans, tachycardia. Are we looking at a narrow complex, wide complex?
It's a narrow complex.
Narrow, okay. Regular, irregular?
It's regular.
Regular. I mean, maybe a little bit of irregularity.
Maybe.
Okay. Okay. But otherwise, the question was, is there P waves? What kind of rhythm it is? But it's at least a regular-ish narrow complex tachycardia. You did point out something. This is QRS alternans, and there's a few like vague ST elevations, ST depressions. These two findings may be just from the tachycardia itself, sometimes rate-related. So after you slow it down, you can recheck to see if they still have an alternance. It may not be related to an pericardial effusion. It may not be related to ischemic disease. So you have to get another one after you slow it down. Then the question, are there P waves? I mean, it's kind of hard to tell in this rhythm. I'm like, maybe this is Flutter waves. I'm not sure. I'm seeing something here. But it's still unclear in this EKG. And just a little side note, this talk's not going to be on EKG interpretation. I actually did this kind of EKG on a Rhythm Nation back in June. If you guys want to see an in-depth talk, it includes wake-bot phenomenon and stuff. But that's for another time. If you guys are interested, we could do more in-depth talk on these kind of EKGs. So let's put together a preliminary problem list, maybe a first year. Kind of just went over it pretty easy. Those could be just the mixer of a Flutter into the QRS. Well, come on, someone shout out. Time. Sorry.
Tachycardia.
Yeah, what kind?
Narrow complex.
Yeah, so rapid narrow complex tachycardia. And then we asked, is this stable or unstable? Talking. Pressure was fine. So what do you guys think?
Stable.
So let's call it stable narrow complex tachycardia. Great. Initial intervention. So maybe a third year. So we got the stable narrow complex tachycardia. What are some? And we're not quite sure what it is. So some sort of SVT maybe. So what might we want to try? Vagal. Damascene. calcium channel blocker right here, all these things. Vago, I don't know if it was attempted or not, they didn't document, but they did give adenosine, 6, 12, 12, like usual. There was no real response that was beneficial. They couldn't really tell anything from the adenosine. Actually, at some point, it was documented that the patient went into 300 beats per minute. It was very brief. They didn't have to cardiovert or anything because it went back immediately. I suspect that maybe this was a one-to-one conduction of flutter waves that then resolved back to this EKG. So EKG number 2 basically looks exactly like the first one. So adenosine didn't really help us. So what's another thing we might want to try? Maybe a fourth year. They're still stable. They're still talking to you.
I really want to know what
What's
the
the
looks like.
How old is this patient?
This is resuscitation. We don't know anything about the patient. We don't care. We're still in resuscitation mode. We'll give you a history in a little bit.
Calcium channel blocker.
Calcium channel blocker,
How old
subdil.
this patient is, guys?
Yeah, the first slide is 58 years old. 58.
I just get a subxiphoid shot of this pericardium.
Ultrasound, yeah. Okay, so this patient got diltiazem, 20 milligrams, kind of worked. They gave another one, it worked. We reassessed them. The heart rate's now 125. So okay, not 200. The vitals are otherwise still good. They got another EKG. Now, what do you guys think? Now that it's rate controlled. Yeah, I hear a little bit of mumbling. I hear the word flutter a few times. So I see flutter there, and I call this with variable conduction. I see a 4-to-1 block, a 3-to-1 block, a 3-to-1, a 3-to-1, a 4-to-1. Okay, so this is a variable conduction. They were like, okay, good, we did some success with the IV. Let's convert him to PO. You got a 60 milligram dose. All right, cool, let's get some more history. So this patient has a history of mitral valve prolapse. A month ago has had an admission for pneumonia. They had a few episodes of SVT that then self-resolved. So they're like, I don't know, let's put him on some metoprolol and discharge him. So they're presenting with, oh, that didn't come out right. That's supposed to circle the 4 days of intermittent palpitations, dyspneic, okay, these are. He is, okay, 4 days, intermittently, I don't feel well, and then it resolves. Oh, you know, my palpitations, resolved. Finally, on the 4th day, he's like, forget about it, I'm just going to come in. Nothing exacerbates, nothing relieves, it kind of just goes away on its own. And otherwise, everything's negative. No chest pain, I don't have an infection, I feel great. Otherwise, eating, pooping, whatever. Past medical wasn't very helpful. He had the mitral valve prolapse, a knee surgery. They started him on the metope, but not taking it, so basically not on any medications. And I promise I'm not doing cocaine, nothing. I mean, maybe you should have asked about Red Bulls, but it wasn't documented. Physical exam, pretty normal. Patient was tachycardic, no murmurs. Everything else looked pretty good. Okay, we have a little bit more information. Let's throw in differential. Well, now that we kind of know the rhythm, what do you guys think? So an atrial flutter, paroxysmal on and off with the variable block. Okay, so I think of this, but the differential should include like what kinds of things may be causing this. So what are some things that I should consider? Thyroid, infection, PE, cocaine.
Withdrawal syndrome.
Withdrawal. Okay, so these are a few of the things I thought of. He has and mitral valve prolapse. I wonder if he has some sort of worsening MR from that. Another thing, you know, whenever you have somebody a flutter of some sort of duration, at some point you want to start to maybe consider that they might be developing a clot. Clot, yeah. Read my mind. All right, atrial thrombus. Okay, so what do you guys kind of want? Shout it out. Macro. Yeah. Thyroid, chemistry, cards consult,
Rectal temperature.
rectal temperature, chest x-ray. Okay, cool. Let me give you what we got. So they kind of pan ordered a bunch of labs. I just highlighted some of the things that looked a little weird to me. A little bit of mild elevated LFTs, the lactate, whatever, 2.7. Does that matter, Dr. Sinner? I don't know. We'll figure it out. We're going to be doing a study on that. Troponin was ordered. It was negative. TSH, negative. Great. Chest X-ray was ordered, you know, because we're going to admit it. Intern. That's a weird looking one. Somebody's pacer pad. Good. Matt? It was just a kind of prominent diaphragm here, but they just called it bipedal hazy opacities. I don't know if it's a mild vision at Alexis. Nothing too significant, no pneumonia or anything. Refined problem list. So we got the atrial flutter, variable conduction, we got some mild transaminitis, a little mildly elevated lactate, whatever. I don't know, an effusion or Alexis. But we're pretty much at the same problem as we first had. They got a cards consult. It wasn't from the ED though, but it was. They eventually got it. They kind of hedged on the diagnosis, but it's a flutter variable block. They recommended admission to CCU. That was great. At that point, the heart rate was still 120 to 140, so they were like, you know, put him on the DILT drip, get it below 110. We're going to order the TEE for the morning, and then we'll try for ablation. So this is kind of yeah.
So it's good. Do you know what was that patient seen in our hospital for pneumonia? Do you know what they got from that patient also?
I mean, they were treated for pneumonia, and then they were discharged them in TOP, and they weren't taking it. So the patient got the adenosine, got 60 mg IV and 90 PO of DILT, then started on the DILT trip and admitted to the CCU. So in the CCU day 1, they got the TE. Great, no thrombus. We could probably proceed with some sort of cardioversion. They saw pretty good EF, and then they saw, oh look, their mitral valve prolapse was pretty bad, moderate to severe MR. Hospital day 2, they got EP ablation. I'm not going to fully talk about this because Dr. Pedalino's here and he was involved in the ablation, so we're very happy that he can come and explain this to us. But it was a typical atrial flutter that had a successful ablation back to normal size. On day 3, discharged. After the patient was in normal sinus, Dr. Pedalino recommended starting Coumadin because there could be electrical dissociation where they might still be having some fluttering of the muscle tissue even though the electrical stimuli is normal. He can discuss that more, but generally you can put him on some Coumadin just until they're completely back to normal. So they said warfarin, put him on the metopen DILT, and follow up in our clinic. And then they were saying, oh, they need their valve repaired because it's bad and it may be contributing to the flutter, so they wanted to send him to CT surgery.
Why so much Coumadin?
That was good. Okay, conclusions. We got a new onset paroxysmal atrial flutter presented in RVR. No response from adenosine, but was rate controlled. Then had a successful EP ablation and probably a very probable contribution of MR, which needs definitive care, and so they were sent to get that care. Great. So that's a case. I really like these kinds of rhythms. For the 3rd and 4th years, I actually gave a talk on atrial flutter. I made this slide at that time. It's kind of like how I thought of all these like tachyarrhythmias. We're not going to talk about all this, but that's how I broke down in my mind, regular, irregular, wide, narrow, so on. But we're going to be talking about atrial flutter for this talk. These are our learning objectives. There's a lot you can talk about for this kind of case, but I wanted to focus on just a brief understanding of atrial flutter, understanding when not to treat, and looking at electrical and chemical cardioversion, and then we're going to be diving into EP ablation. So briefly, AFib is similar to A-flutter. I mean, A-flutter is similar to AFib, but generally it's not like a healthy young person who comes in. Generally there's something else going on, so you always got to think of the inciting incident. I want to make a special note that MI itself isn't on here. So someone who comes in and completely asymptomatic with just these palpitations, you do not necessarily have to rule them out for ACS just because of this rhythm. Okay, so if they have some other story or whatever that might clue you into an ACS, sure, but it's not a primary cause that needs to be ruled out in every A-flutter. What this is, a flutter is a macro reentrant, and it involves the whole right atrium. And it goes at about 300 beats per minute. Let me just show you. So we have our right atrium, and it goes macro reentrant. And I want to, so this right here is the tricuspid valve, and this red dense area is the tricuspid isthmus. And basically it rapidly goes around the right atrium, and then it slows down here. So a majority of the time that this reentrant is taken up in this isthmus. And it's important to know because Dr. Pellegrino is going to talk about how that's the area that they go to both analyze whether this is atrial flutter and try to ablate, because that's where most of the time is spent. So he will discuss that more later. And then it goes through the AV node, and the AV node is there to protect us. So although the flutter waves are occurring at 300, the ventricles can't really handle 300 beats per minute for that long, and then it may degenerate into a VFib. So the AV node tries via a conduction blockade. It's called block, but it's just a normal refractoriness of the AV node. It's not like a pathologic block or anything. But it tries to blunt some of those 300 waves, so every other one or every two, it might only let one of those waves go through. And so here's an example. You'll see the classic flutter waves on the EKG. And these flutter waves, like I said, are going at about 300 beats per minute. If you remember, one big box, 5 millimeters, is the time it'll be for 300 if you're doing the rate, 300, 150, and so on. So you'll see these flutter waves at 300. Note, fib's kind of confused with flutter, because coarse fib has these like fibrillatory waves, but those fibrillatory waves are often like closer together than these flutter waves. So if you see fibrillatory waves like 4 millimeters or less apart at a rate greater than 300, then it's very unlikely that it's flutter. So that's kind of a way you can distinguish it. So this is about 300 beats per minute. Then you can count how many flutter waves for one ventricular wave. So here you see there's 3 flutter waves and then 1 ventricular wave goes through. So this would be a 3-to-1 block. So the AV node is taking in 3 flutters and only releasing 1. And that will give you about 100 beats per minute. And then if the 2-to-1, which is the most common presentation, would be 150. So if you ever see an EKG, SVT that's like strictly 150, keep this in mind, flutter. And then 75 beats per minute for 4-to-1. And then you could also have variable conduction, where sometimes it's 3-to-1, sometimes it's 4-to-1. Okay, so these are the main topics I wanted to talk about today. When not to treat, talked about electrical cardioversion, chemical cardioversion, and EP ablation. This is just so we can visualize where we're headed. All right, everyone good? When not to treat. First, do no harm. So Dr. D'Souza sent this article out to us. It was just released in the Annals 2015. It's an excellent article. And basically, let's go into it. So it was a retrospective cohort, and they said, okay, let's look at our patients who came in with flutter, but also something else. They considered it complex flutter. So they came in septic with flutter, they came in CHF with flutter, they came in ACS with flutter. So something else, or flutter was not the primary diagnosis. And then they looked back at how the doctors treated it. Some doctors said, oh my God, flutter, rapid atrial, whatever, give DILT, give adenosine, give amiodarone. Some doctors said, oh, let's focus on the CHF, let's focus on the hypovolemia, let's focus on the sepsis, we'll worry about the flutter later, and let them be in flutter for some amount of time. So they broke it off into 2 groups, treating the underlying and rate or rhythm control of some kind. The primary outcome was safety, and then success and adverse reaction. So, looking at the primary outcome. So these are our rate and rhythm control people, so they immediately jumped on with DILT or adenosine or something like that, and they noticed a 6-fold increase in adverse events versus the people who investigated and treated the underlying. Okay? So, early rate control, DILT and stuff had a 6-fold increase in adverse events compared to the group where they focused on the sepsis and CHF. Also a 12-fold increase in major adverse events. So a minor one, the 6-fold, is like, I don't know, he became briefly hypotensive, I gave a liter of fluid and it was fine. His O2 went a little bit down, I bagged him for a second and it was fine. Whereas a major was like, he required pressors, intubation, like pacing, something. So these are pretty shocking numbers for just giving these. And secondary, this was actually very interesting as well. So they're like, let's analyze the success of these rate and rhythm controls. So for rate control, they looked at, okay, if someone comes in immediately, I give them DILT, how successful is that at really treating the heart rate? Or do I wait 4 hours and then give them DILT or something? Is that more successful? And they noticed that it was more successful at the 4 hours than if they gave it right away. And conversely, the adverse events were higher if you immediately treated them than if you waited 4 hours. So success improves for rate and rhythm control over time, but adverse events decrease. So this further evidence, maybe we should be investigating, treating underlying, and holding off on these like rate controlled stuff. They noticed that there was a lot of different underlying conditions that people came in as the primary cause. The two most common were CHF and sepsis. So that was about 60% of all the patients who came in with an underlying condition and then got a flutter was CHF and sepsis. Whereas they noticed that there was no difference in adverse events. So an adverse event happened in each of these groups equally. So it doesn't matter what they came in with, their chances of having a bad outcome was about the same. But I just want you guys to pay attention. These are two big reasons why maybe someone will come in and flutter, so you can keep it in your mind. Now, one more thing I thought was interesting from this paper. So they looked at someone who came in, they treated the underlying. Now let's focus on what they came in for. Maybe they gave some antibiotics, and maybe they gave just fluid resuscitation. Let's give them 1 or 2 liters, see what happens to their heart rate. And within 4 hours later, they noticed a 44% decrease in heart rate, just from giving like a liter or 2 of fluid. Okay? Then they looked at the same group, at the next group, the people who gave DILT and stuff to, and who they did not really focus on fluids. 4 hours later, there was only a less than 20% decrease in heart rate. So they were like, I wonder if a lot of these aflutter patients are just hypovolemic, because giving more fluids did a lot better job than our drugs did. So that was another thing that I thought was interesting to keep in mind. What do the guidelines say? Okay. So the AHA guidelines in 2014, they gave a class 1, treat the underlying cause. They gave an evidence level C, which is, we don't have a lot of data, maybe expert opinion. But this was 2014, and this new article I just talked about was 2015. So I think maybe they'll bump up the class evidence, because that was a pretty compelling paper. So good, we have some support for treating underlying. All right, next topic. Electrical cardioversion. Okay, a little bit of background. So for this talk, we're going to be talking about less than 48 hours of symptoms, of continual symptoms. So I know it happened, it started yesterday. This is less than 48 hours. Now there's a lot of vagaries here. How do we know when symptoms started and stuff? These are big limitations, but generally they say if we're pretty comfortable that it's within 48-hour window, we can electrically cardiovert. Briefly mentioned, some places talk about fasting when you're going to shock somebody. There's a lot of new evidence of saying, for procedural sedation, for cardioversion, we may not need to fast. The verdict's still out. I'm just bringing it up, but each person can decide if they think they need to be fasting. Maybe if they have a mouthful of a Whopper is not a good time to shock them, but I don't know. These kind of electrical cardioversions, I mean, if you want to be nice, some sort of procedural sedation analgesic, it might be good. Sometimes I like to come up behind them and there's... No, okay, I don't know. I promise. Lastly, atrial flutter. I want to stress this. It's very easy to cardiovert them out. It is like the lowest amount of joules that you need of any of the other tachyarrhythmias. It's a big macroreaction circuit. You just need to knock it out and it's good. So 50 to 100 joules. These aren't the 150 to 200 joules that you'll do for other arrhythmias. What do the guidelines say? Well, they say with less than 48 hours and low risk, you can do it with or without anticoagulation. So it's kind of like hedging, and they don't really say what low thromboembolic risk is. Other places in the paper used CHADS 2 VASC as a measure of low risk in other segments, 0 or 1 or something. They don't specifically use it in this segment, so I can maybe infer that that's what they meant, but it's kind of a little hedging. Okay, so I told you it's very good success. Let me prove it to you. There's like many papers that looked at success rates in electrical cardioversion. There's a systemic review, some other lit reviews. Overall, we looked at many studies that included clinical trials and cohorts and observational and retrospective, and pretty great success comparing electrical cardioversion to chemical cardioversion with meds. 80 to 96 versus like in the 50s. Okay? So this is pretty compelling evidence. In med school, we always learned that huge big risk, you know, oh, you're going to zap somebody, you got to make sure they don't have a thrombus because, you know, drill it into your head. You don't want them to stroke out or pee or something. So this is one thing that we've always feared. So there's studies that look, is this a safe thing to do in the ED, or are they going to all stroke out? Let's look at two specific articles. There's a bunch. This is a big study. It was like 5,000 patients, and they basically looked at those who were cardioverted, and they followed them for 30 days. It was in an area where everyone goes to the same hospital, so they knew they were going to capture everybody. And they looked at what kind of complications happen from electrical cardioversion. So they only looked at people who were cardioverted less than 48 hours of symptoms without anticoagulation. So that's our people. They saw high success rates. Most of them were electrical, but also they did some chemical. But overall, 95% success rate. And they saw an embolic complication risk of 0.7% within 30 days. Pretty good, less than 1%. Then, a year later, they're like, we can do better. Same group, they reanalyzed their data, and they broke it down. Instead of less than 48 hours, they wanted even finer detail. So they said, we actually noticed for the less than 12-hour group, it was only 0.3%. And then for the rest, overall it was 0.7, but it got higher if you waited up to 2 days. So maybe, you know, we have a patient, we're pretty sure this is new. It shouldn't be let's admit them, maybe tomorrow they'll get ablated by the MICU team or something like that, or maybe they'll get cardioverted tomorrow, because I have a whole day, you know, until it becomes 48 hours. But maybe we should be doing it early, right as we suspect it, and the risk is even less. And maybe we don't have to admit it. So that's electrical cardioversion. Let's move on to chemical cardioversion. So what is this? I use the term chemical cardioversion, but you've also heard it as rhythm control. We have rate control, rhythm control. Sometimes you can use it as pre-treatment before you shock them. Sometimes you can use it instead of shocking them, and maybe patients you're afraid to sedate, or they have maybe other complications that you don't want to mess with, and you'd rather just give them the medication. There's many options for these. Lots of literature that's showing different, the sotalol, propafenone, all these other drugs. I just want to, for this talk, I want to talk to you guys about Ibutilide, because I thought that was a very interesting drug. Now, a little background. Here at Kings County, we basically use procainamide. That's what they have. I really tried to make Ibutilide because we were putting together a video, which I'll talk about later. And I was like, can I just hold a bottle of Ibutilide? And we don't have it. Okay. Maybe in like the EP lab or something, but the ED can't get Ibutilide. But here at City Downstate, I called the pharmacy and they have it. So we can get it, and I definitely want to try it next time I'm in UHB and if the right case comes up. Let's talk about, okay, what do the guidelines say? They're like, class 1, yeah, do it, meds. Lots of meds. Okay, Ibutilide was on there, so good, let's talk about it. Chemical cardioversion Ibutilide. It is a class 3 antiarrhythmic. What does that mean? That means it blocks the outflow sodium channels during the repolarization phase in the action potential. Okay? So this will prolong the repolarization, so you'll get a widening QT interval, and it'll just delay the repolarization enough to where that reentrant won't, it'll be, by the time it reaches back around, it'll be in repolarization. Usually they talk about a rapid infusion over 10 minutes, but you could put them on a drip over 8 hours. But generally it's take a milligram and you put it over 10 minutes, and you could try that again if it fails. Chemical cardioversion, what's the evidence? Lots of evidence. You know, Dr. Souza, Dr. Chan, Johannes, they sent me like 10 articles on Ibutilide, a lot of clinical trials comparing Ibutilide to many other drugs, observation. There's a lot of evidence for this. I'm just going to talk about two things, this article and this article. So one was it was a clinical trial against procainamide, Ibutilide versus procainamide, and one, because that's what we use here, so I thought it'd be interesting. And the other one was just a big systemic review looking at a lot of different comparisons of Ibutilide, many studies. Overall, they're showing efficacies in atrial flutter 50 to 70%. It's pretty good. It's not as high as 96 in electrical cardioversion, but for that specific trial comparing Ibutilide to procainamide, these are huge numbers. Look at this. 76 versus 14%. Ibutilide kicked procainamide's butt. And looking at side effects, procainamide had way more side effects. Hypotension, headache, dizziness, all this stuff. Ibutilide, you got to monitor QTC. Make sure they're not on any other QT prolonging meds. I think I saw one study that saw one episode of torsades. Torsades is easy to get rid of. I'm doing another thing on torsades we can talk about, but pretty much Ibutilide has been shown to be safe. Okay, last thing I want to talk about, putting it all together. So there's a lot of different programs that are creating some sort of algorithm. I know Dr. Souza is trying to create an algorithm right now for us. And I'm going to look at one specific one. It's Ottawa. Ottawa loves to create all these projects. In Canada, they use this Ottawa aggressive protocol, and they publish it. It's like the largest study showing that what they've actually done. And so basically, they saw about 600. Those doctors all kind of decided to agree. Hey guys, let's cardiovert these people. And they're all like, yeah, okay. So then they looked at all the patients who came in with primary A-flutter and AFib, and then they tried to cardiovert them all, and they wanted to see what would happen. Are we being too aggressive? Did a lot more people die? And so they did a cohort study analyzing this. And so you see 660 patients, and they basically showed like 97% of them were successfully cardioverted and discharged home. And initially, about 50% were, so at their institution, they decided first we'll do procainamide, then we'll electrocute them. And about 50% were successfully cardioverted with just the procainamide. And then the rest, another like 98, were successfully cardioverted with the electricity. So that pretty much most people were successful. And then they discharged 97%.